Hello all. Today we'll be discussing the rest of question which was there in the RCP website, the sample question with some detailed explanations to the answers. So let's get started. Question 21. A 50-year-old man presented with a 2-day history of multiple painful joints. 2 weeks previously had been started on treatment with allopurinol for tophaceous gout. His only other medication was paracetamol. He had a history of excess alcohol intake. On examination, his temperature was 37.5 and there was acute inflammation of the finger joints, wrists, knees and ankles. So the patient is having gout and was started on allopurinol. That's the only new drug that is having. Other than that, he's taking paracetamol and it's a acute onset or 2-day history of multiple painful joints. To 2-day history of multiple painful joints, and he was started on allopurinol. When there is any drug that the patient is newly started on, and if the question is regarding some of the side effect or the adverse event or anything related to that drug, always take care of that. So when there is a history of starting allopurinol just 2 weeks previously, think about any connection to the newer drug or already taking paracetamol. Now he's having multiple painful joints. Serum GGT is 90, CRP is 180, urate is 0.65. So uric acid is high. What is the most likely cause of his symptoms? We'll look at the options. Acute calcium pyrophosphate deposition disease, which is called pseudogout, alcohol intake, allergic reaction to allopurinol therapy, septic arthritis. See, we have two options regarding allopurinol. One is allergic reaction, one is allopurinol therapy itself causing multiple painful joints. Now, allergic reaction to allopurinol can get severe and can cause even SJS. Allopurinol is one of the known culprits for Stevens-Johnson syndrome or completely erythematous rash all over the body after starting allopurinol. That is the reaction, adverse reaction to allopurinol. Here, the case is not rashes or something, it's painful joints. So the answer is allopurinol therapy, because once we start allopurinol to a patient, the patient can have severity in their symptoms. They can have multiple joint affection, because initially in acute gout we should not start allopurinol alone. The recommendation is to start NSAIDs along with allopurinol and then continue NSAIDs for some time and then give allopurinol. Okay, so you have to always give NSAID along with allopurinol, otherwise they will have worsening of their symptom. Here it is not septic arthritis, because septic arthritis usually affect one joint. There will be warmth and high-grade fever and high CRP and high count, which is not here. And pseudo-gout, not the case. Alcohol intake itself would not cause a worsening of gout. Okay, so it is allopurinol therapy which has caused the symptoms. Always start NSAIDs along with allopurinol. Next question. A 17-year-old boy presented with breathlessness and night sweats. Investigations confirmed a diagnosis of Burkitt lymphoma. What is the most likely underlying abnormality of gene expression? So a very straightforward question. What is the gene abnormality seen in Burkitt lymphoma? So some of the hematological malignancy especially, you have to know the gene abnormality. For example, we look at the option, the BCR-ABL, the known culprit of CML, chronic myeloid leukemia, BCR-ABL, translocation 15-17, that is called the Philadelphia chromosome. Loss of P53 is can cause many cancers, many malignancies, even hematological and otherwise, even breast cancer, so many malignancies. Overexpression of BCL2, no. Overexpression of c-MYC, that is a thing in Burkitt lymphoma, which is actually translocation 814. 814, that is called c-MYC expression, that is seen in Burkitt lymphoma. You have to know these things. Overexpression of JAK2, that is the thing, or a Janus kinase, that is polycythemia rubra vera. polycythemia rubra vera, that is this thing. So Burkitt lymphoma, it is translocation 814, and that is expression of c-MYC. You have to know certain things. Next question, a 37-year-old woman with immune thrombocytopenia failed to respond to corticosteroid therapy. Splenectomy was planned. What is the optimum time for pneumococcal vaccination? So regarding splenectomy, the patients usually receive vaccines like pneumococcal vaccine, meningococcal vaccine, and influenza vaccine. Influenza vaccine is repeated yearly. Pneumococcal vaccine is given every 5 years, and meningococcal vaccine, because they are prone to get infected with these capsulated organisms, so they are given vaccines. And this is one of the favorite question: when is the optimum time for pneumococcal vaccine? It is ideally 2 weeks before surgery, but in the option, only option close to that is 1 month before surgery. So that is the option. It is 1 month before surgery, and it is repeated every 5 years. Influenza vaccine repeated every year, and we also get meningococcal vaccine. Next question, a 30-year-old man had moved recently to UK. He is informed that he had maturity onset diabetes of young. What feature, if present, most strongly suggests that this is the correct diagnosis? So we have two things. One is MODY, that is maturity onset diabetes of young, and one is LADA, latent onset autoimmune diabetes seen in adult. So here what I kind of try to remember is, see, MODY is maturity onset diabetes of young, so seen in young patients, but it is more so likely to be like type 2. It is not the problem with the insulin production like seen in type 1. The insulin is not low. It is more so like type 2, but it is seen in an early age. You see, young means it is seen in young patient, but it is more so like type 2. LADA is, it is seen in adult, but more so like type 1. So there is absolute decrease in insulin production. So for LADA, you have to give insulin. For MODY, more like type 2, you treat like that. Okay, so which option suggest maturity onset diabetes of young? Options are BMI of 30, poor response to glyphosate, recurrent episodes of diabetic ketoacidosis, strong family history of diabetes mellitus, X-linked recessive inheritance. So think of type 2 diabetes. So type 2 diabetes has a stronger family history and a stronger genetic predisposition than type 1. We often think like type 1 comes early, so that has a more stronger link to the family and genetic predisposition. No, type 2 has a stronger association with the family history and genetic predisposition. So that is more so like the type 2 thing. Diabetic ketoacidosis has stronger association with type 1, and also it responds more to insulin and not to OHAs. So poor response to glyphosate therapy also suggests type 1 like picture. So the answer is strong family history, because that is suggesting a picture like type 2, which is the characteristic of maturity onset. Okay, so that is strong family history of diabetes mellitus. Always remember, type 2 has a stronger genetic predisposition and stronger HLA association. It is associated with HLA-DR4. Okay, diabetes mellitus associated with HLA-DR4. Next question, a 17-year-old girl present with single painless enlarged cervical lymph node. She was asymptomatic, and chest X-ray showing enlarged mediastinal lymph nodes. So look at the age, look at the presentation. There is cervical lymph node along with mediastinal lymph node. What all comes to your mind? We look at the options and think about it. Okay. So the options are angioimmunoblastic T-cell lymphoma, extramedullary plasmacytoma, follicular B-cell non-Hodgkin lymphoma, Hodgkin lymphoma, and mantle cell lymphoma. So see, Hodgkin lymphoma, we have an ARPA staging, which states that stage 1 is above the diaphragm and only one side is affected. Stage 2 is above the diaphragm but both sides are affected. Stage 3 is uh, uh, above and below the diaphragm, and stage 4 is a distant metastasis. And in an age like 17-year-old with a mediastinal lymph node along with a cervical lymph node, think of Hodgkin lymphoma, because non-Hodgkin lymphoma usually present in an extranodal manifestation, but Hodgkin lymphoma present with the nodal, like lymph nodes will be affected. So that is Hodgkin lymphoma, and this is the Ann Arbor staging. Stage 1 is localized disease, single lymph node or single organ. Stage 2 is 2 or more lymph nodes on the same side of diaphragm. Stage 3, Stage 2 is more than one and same side. Stage 3 is 2 or more above and below the diaphragm, and stage 4 is widespread disease with distant metastasis to the liver or bone. And remember, when the spleen is affected, it is still in stage 3. So stage 3 includes also your spleen, because spleen is considered as a lymph node in Ann Arbor staging. It's not considered as a distant organ. So if you have above and below with along with spleen involvement, don't think of like a distant metastasis. It is still stage 3 because spleen is considered as a lymph node. So this is Ann Arbor staging for Hodgkin lymphoma. Next question, a 70-year-old man presented accompanied by his wife who stated that her husband had lost all interest in life. What would support a diagnosis of dementia rather than depressive disorder? So all interest in life, okay? Uh, all interest in life and activities he used to enjoy previously, that is classical of depression, hopelessness, helplessness, worthlessness. We've studied that in psychiatry, right? But here they're asking what is characteristic of dementia and not depression, because dementia and depression more or so many characters are and features are similar. So look at the options: agitation, complaint of poor memory, that can happen in both dementia and depression; impaired short-term memory, again both in dementia and depression; loss of libido; urinary incontinence. See, urinary incontinence is unlikely in a depressive disorder. It is more suggestive of your dementia rather than depression. So the answer is urinary incontinence. Next question, a 48-year-old woman was admitted to the emergency department with a 2-hour history of hemoptysis. She had been treated for pulmonary TB when she was 30 years old and had developed a right upper lobe cavity containing an aspergilloma. She continued to cough up large amounts of blood over the next 24 hours, and the decision was made to perform a radiologically guided embolization. Which blood vessel is most likely to be the target of embolization? So this is and if you know kind of question. So there is hemoptysis. She was treated for pulmonary TB, and this is a right upper lobe cavity. She's having hemoptysis and large amount, maybe large hemoptysis, and now she's taken up for radiologically guided embolization, which is the vessel target of embolization. The answer is bronchial artery. Bronchial artery. Next question, a 32-year-old woman returned from holiday in Mediterranean with a suntan and numerous hyperpigmented, slightly scaly lesions on the neck and upper trunk. She mentions that the same areas had been fawn-colored in the months before the holiday, and these areas of skin had failed to tan during her time in the Mediterranean. What is the most likely diagnosis? A dermatological question. You have to know bits and bytes here and there from dermatology. You have to know the kind of distribution, the morphology of the lesions, and the usual presentation, and any association like photosensitivity or scarring, scaling, all these things. So here we'll dissect this question and discuss the options given here. So here the areas had failed to tan, and even previously before her um, vacation itself, it was discolored, fawn color in the months before, and now it's slightly scaly, hypopigmented lesions. So it's not a new lesion with sun exposure. It has actually failed to tan during sun exposure. So we'll look at the options. Chronic plague psoriasis. Psoriasis usually presents in sun-exposed regions. Again, that can be scaly, and the lesions can be really itchy. Plague psoriasis, the lesions would be morphologically a little bit plague-like. But here, that is not the presentation. Discoid eczema, that can be erythematous and severely pruritic, not the case here. Pityriasis rosea, that is again erythematous lesion that has a classical thing called herald patch. Herald patch is the first patch that is to be seen in pityriasis rosea, and then it spreads from there. Usually seen on the back. Okay, that is called a herald patch, which is the first initial lesion that is seen in pityriasis rosea, which is again erythematous, not hyperpigmented. Pityriasis versicolor is the one that is the diagnosis here, because it is hyperpigmented lesions, which also fail to tan. Seborrheic dermatitis usually presents in nape, you can have it in your cheek, your nasolabial fold, maybe in the neck, especially in the areas where there is more oil production. Not the case here. So the diagnosis here is pityriasis versicolor. So this is a pityriasis versicolor where there is hyperpigmented lesions which fails to tan. And this is what I told you, herald patch, which is the initial patch seen in pityriasis rosea. Next question is 65-year-old woman developed bilateral lower limb swelling. She had been taking regular ibuprofen for joint pain for the previous 2 weeks. She had a past medical history of urinary tract infection. On examination, BP was 139/98, and she had pitting edema below the knees. Urine analysis showed protein 2 plus red blood cells, 1 plus leukocytes, 3 plus NO nitrites. Creatinine is 458, and urine protein creatinine ratio is 130. What is the most likely cause of renal impairment? So here we are asked the cause of renal impairment. What is the renal impairment? There is proteinuria, there is hematuria, and there are no nitrates, and that means it's not a UTI now. The creatinine is also elevated, urine protein creatinine ratio is raised, and we are given a drug. Like I told, when there is a drug history, always look if the drug is the culprit here. Yeah, ibuprofen NSAID, which is known for causing acute interstitial nephritis. So that could be the presentation. We look at the options, and it is a 65-year-old woman. She had no past medical history of UTI or even renal impairment. There is nothing given. Now she has pitting edema, and her urine analysis showed proteinuria and hematuria. She had NSAID intake. So think of acute interstitial nephritis. They might also give a value of eosinophils, which can be raised. There can be eosinophilia in acute interstitial nephritis. So when you see eosinophilia, don't get confused. It is associated with interstitial nephritis itself. The presentation can be proteinuria and hematuria following NSAID intake. Options are acute tubular necrosis, IgA nephropathy, membranous glomerular nephropathy, papillary necrosis, and tubular interstitial nephritis. So this is the option, tubular interstitial nephritis or acute interstitial nephritis. Next question, a 47-year-old man present with a 6-month history of episodic sweating and hunger. He had gained 10 kg in weight and drank 10 units of alcohol per week. His blood count is normal. Fasting plasma glucose is 3, lower limit of normal. Liver function test is normal. What is the most appropriate Next investigation. So he's having episodic sweating and hunger, and his plasma glucose is low. He's 47-year-old. He has gained 10 kg and drank 10 units of alcohol. We look at the options first. CT scan of pancreas, endoscopic ultrasound scan of pancreas, plasma glucose concentration following a prolonged 72-hour fast, serum C-peptide concentration, serum insulin level. So when you look at the options, you may get an idea. Sometimes you go blank once you read the question. Also look at the options, because that can give you a hint of what diagnosis they are asking. So the patient is having episodic hunger and sweating, and his blood glucose is lower limit of normal. That means he is having recurrent hypoglycemias. That means he may have insulinoma, which is a rare tumor. It can happen rarely, but this presentation is more likely to be insulinoma, and the diagnosis is made by investigating plasma glucose followed by a prolonged 72-hour fast, or a supervised fast, that is called. That is the diagnosis for insulinoma. Serum C-peptide, so it can be insulin abuse also, it can be insulinoma also. So if there is, in the question, if there is some mention of a possibility of insulin abuse, like somebody from their home is taking insulin, or they are a pharmacist, or there is anxiety or psychiatric illness, if there is something mentioning that make you think that there can be insulin abuse, think of that. But in this case, it's unlikely. So it can be an insulinoma. Then you have to look for plasma glucose concentration following a 72-hour fast. Serum C-peptide, you can look for to identify if the insulin is endogenous or exogenous, because exogenous insulin lack the serum C-peptide. Only endogenous insulin has C-peptide levels. So if there is high levels of insulin by endogenous production, there can be high levels of serum C-peptide along with it. Otherwise, if the patient is abusing insulin abuse, if they're taking exogenous insulin, they will lack serum C-peptide. So maybe insulin levels will be high, but serum C-peptide will be low. That will indicate insulin abuse. Not the case here. So this is a diagram showing what happens in insulinoma. It is a most common pancreatic islet cell tumor, but insulinoma as such is rare. It is the most common cause of endogenous hyperinsulinemia. So when there is hyperinsulinemia, if it is endogenous, it can have, along with insulin, it can have C-peptide also. But exogenous insulin is made after removing that C-peptide. In our body also, C-peptide is removed when they have an alpha chain, beta chain, and a C-peptide. C-peptide is removed and made into mature insulin. So in our body, C-peptide will be there, but exogenous insulin lack this C-peptide. Okay, our body will have insulin, pro-insulin, and C-peptide. And it is a tumor of the pancreatic islet cell, or a beta cell tumor, because beta cell are the one that is producing insulin. So there will be recurrent hypoglycemias. And the treatment includes treatment to reduce insulin, which includes your octreotide or somatostatin analog, or diazoxide. Or you can reduce the tumor burden by dacarbazine and temozolomide. I haven't seen questions regarding the treatment of insulinoma. Even if they are asked, it is most commonly somatostatin analog, which is octreotide. Okay, and surgical resection. Next question: a 25-year-old woman presented complaining of having loose stools 5 to 6 times per day. 1 year previously, she had undergone resection of her terminal ileum for Crohn's disease. Her only drug therapy was mesalazine. On examination, there was no abdominal tenderness. HB is 12.6, albumin is 38, fecal calprotectin is 65. So fecal calprotectin is one you do to differentiate between IBD and IBS. That is irritable bowel syndrome and inflammatory bowel disease. So fecal calprotectin, if it is high, it indicates inflammatory bowel disease, which is Crohn's and ulcerative. But if it is here, it is not that high, that means it is irritable bowel. It's not likely to be associated with your Crohn's. So here they are having loose stools 5 to 6 times per day. She had undergone resection for, so this is the key here, resection for terminal ileum of Crohn's disease. Now we look at the options and then you will identify the answer. What is the most likely diagnosis? Options are active Crohn's, but here fecal calprotectin is not that high, so it can't be active Crohn's. Adverse effect of mesalazine, bile salt induced diarrhea, enteric infection, irritable bowel syndrome. So here it is bile salt induced diarrhea that can be a complication post resection in Crohn's disease. So think about that. If there is a history of resection and following that they are having diarrhea, think of bile salt induced diarrhea post resection. Next question, a 71-year-old woman required a transfusion of 2 units of blood after hip replacement. 1 week later, her HB had fallen by 4.2. What associated finding is most likely to indicate a delayed transfusion reaction? So what happens in a delayed transfusion reaction? There is some kind of antibody interaction in delayed transfusion reaction. So that means there will be antibody and some test that can detect this antibody will be there. So we'll look at the option. Conjugated hyperbilirubinemia, wrong. Because in hemolytic reaction, because there is hemolysis due to the antibody. So in that unconjugated hyperbilirubin is elevated. So there can be unconjugated hyperbilirubinemia, not conjugated, because when there is hemolysis, that heme will get converted into biliverdin, then to bilirubin. Bilirubin will bind to albumin, which is called your unconjugated bilirubin. That goes to the hepatocytes that will convert this unconjugated bilirubin into conjugated bilirubin. Okay, that is the step happening inside the liver. So that when there is excess of hemolysis, excess of biliverdin, excess of bilirubin will be produced, that will bind to the albumin and increase the unconjugated bilirubin fraction, not the conjugated level. Okay, conjugated will be mostly elevated if there is some stasis when they enter the common bile duct. So there can be a tumor or stone that is obstructing the pathway. So usually in obstructive jaundice, not in hemolytic jaundice. Elevated D dimer? No, not likely. Hemoglobinuria. Hemoglobinuria can happen when there is an intravascular hemolysis. When there is an antibody interaction outside the blood cell, it is usually extravascular when there is no hemoglobinuria or hemosideриnuria. Both happens in intravascular hemolysis, not in extravascular hemolysis. Positive direct antiglobulin test. This is the answer, because direct antiglobulin test is other name for your Coombs test, which is identifying the antibody present in the serum. Okay, so that is the answer, positive direct antiglobulin test or your Coombs test. Next question, a 30-year-old woman presented with a 4-hour history of palpitation. She had no significant medical history. Investigation showed atrial fibrillation with a ventricular rate of 130 beats per minute. What drug is most likely to restore sinus rhythm? So, short onset AF, okay, because she has a 4-hour history of new onset AF with high ventricular rate. AF with FVR. AF with FVR means atrial fibrillation with fast ventricular rate, and that also acute onset. What is most likely to restore the rhythm? And this is a key here. She had no significant past medical history. So if there is no past history, no non-cardiac illness, the very effective drug is flecainide. Flecainide. Which class is flecainide? Flecainide is a class 1. Class 1 antiarrhythmic. Uh, so if there is no past cardiac disorder, the most effective drug is flecainide than your amiodarone. Here, amiodarone is also not given as an option, so the option is flecainide. So this is a summary of our antiarrhythmic drugs. We have class 1 to 4. We also have a class 5, which includes a digoxin and all. Class 1 is sodium channel blocker, which again is divided into 1A, 1B, and 1C. 1A means moderate action, 1B is weak, and 1C is strong. 1A includes quinidine procainamide, 1B is lidocaine mexiletine, 1C is your flecainide and propafenone, which acts on the sodium channel. Sodium channel is in the phase 0. Phase 1, it is potassium, and that is okay. And phase 2 in the cardiac cycle is the plateau phase, where the calcium channel also opens and there is influx of calcium. That is your class 4 calcium channel blocker. So class 1 is sodium channel blocker, class 2 is beta blocker, which is propranolol and metoprolol. Class 3 is potassium channel blocker, which is amiodarone sotalol, and that acts on the phase 3 of cardiac action potential, where the potassium efflux happens and the calcium channel is already closed. So that is the potassium channel blocker, which is your amiodarone sotalol. Class 4 is calcium channel blocker, which is verapamil and diltiazem, which is acting on the phase 2. So that was your antiarrhythmic drugs. Coming to next question, a 20-year-old woman presented a 2-month history of intensely pruritic rash on her trunk and limbs. She was otherwise well. On examination, she had multiple violaceous flat-topped papules of the flexor surface of the wrists and on ankles and lower back. The papules were aggregated in a linear fashion at one side on her left forearm. What clinical feature is most likely to be present? So you have to first identify what is the diagnosis. Dermatology, when you first see the question, can seem a bit overwhelming because there's different morphology for different lesions. The distribution is different, the kind of presentation, the association, photosensitivity. There's so many things. But once you crack the keywords, it becomes easier. So here, violaceous, that itself should make you identify the diagnosis. We'll see the rest. Flat top papule, okay, and they are aggregated in a linear fashion. Some sentences would have no much significance. Don't look at everything and don't get confused. It's intensely pruritic. So pruritic, violaceous or purplish. Papules, what do you think? It is lichen planus. And they are asking what is the most likely clinical feature. We'll look at the option asymmetric oligoarthritis, not associated with lichen, right? Burrows in finger webs. What is burrows in finger webs? They're talking about scabies, not the diagnosis here. Conjunctival scarring. No, lichen planus do not have that conjunctival involvement in all. Involvement of buccal mucosa. That is there. Lichen planus can have involvement of buccal mucosa. The lesions can be inside the mouth also. Non-scarring alopecia, again, no. So it is involvement of buccal mucosa. The diagnosis here is lichen planus. There is also something called Wickham's striae. That is a lacy, white lacy arrangement on the lesion. And see, it is purplish. Purplish, planar. The different morphology, it can be planar, papule, or plaque. So different morphology. Polygonal and pruritic. This is, we call it 5P or 6P of lichen planus. That is purplish, pruritic, polygonal, plaque, papule. It can be also flat topped and planar. And there is something called Wickham's striae or white lacy arrangement of the lesion. And it can involve the buccal mucosa as well. Next question is 60-year-old woman with rheumatoid arthritis presented with an acutely inflamed right knee. The joint was aspirated methylprednisolone 80 mg was injected after the removal of 20 ml of non-purulent synovial fluid. The knee improved following this procedure, but her symptoms recurred and became much worse a week later. Investigation showed HB is 10.5, white cell count is 15,500, neutrophil is 13,500, and ESR is 55. So there is raised white cell count, which is more neutrophilic. And she has rheumatoid arthritis. She had presented with acutely inflamed right knee. It was aspirated, methylpred was injected. She was okay, but now it has recurred and it has become much worse. So we'll look at the options. What is the most appropriate next investigation? So here our strongest and important differential is septic arthritis. So to rule out septic arthritis, we have to do a synovial fluid culture, because the septic arthritis, the organism not always get into the bloodstream. Blood culture might not be useful. CRP will just tell you whether there is an infection or not. So the option is synovial fluid culture to rule out septic arthritis. Next question, a 75-year-old man presented with weight loss, lethargy, and repeated hemoptysis. He had been treated for pulmonary TB 10 years previously. Serum IgE for aspergillus is positive. Serum IgG for aspergillus is also positive. Chest X-ray shows a solid lesion with an adjacent crescent-shaped radiolucency with the left lung apex. What is the most likely diagnosis? So, a patient who was treated previously for TB. So TB can cause cavitation. So remember that. TB can cause cavitation. Now he is presenting with weight loss, lethargy, and repeated hemoptysis. And aspergillus, the diagnosis is here itself. Aspergillus IgE is positive, IgG is positive. So that means in a cavity, there is a fungal bole. That is called aspergilloma. That's why we have a solid lesion with adjacent crescent-shaped radiolucency at the left lung apex, because usually in apex we have TB. So TB might have made a cavity. In that cavity now we have a fungal bole. So what is diagnosis? Is it allergic bronchopulmonary aspergillosis? No, it's a fungal bole. What is that called? It's aspergilloma. Allergic bronchopulmonary aspergillosis is not the case, because that does not present with a classic fungal bole. Angioinvasive aspergillosis? No. Bronchial carcinoma? No. Reactivation of TB? No. So this is aspergilloma. We'll just see what is the difference between asthma, allergic bronchopulmonary aspergilloma, and extrinsic allergic alveolitis. Okay, aspergilloma, we know it is a fungal bole. You will have aspergillus Ig will be positive. In asthma, there is hypertrophied mucus glands. In allergic bronchopulmonary aspergillosis, there is colonization of airways. There can be viscid mucoid impaction and tissue eosinophilia. So there is eosinophilia in this ABPA. Extrinsic allergic alveolitis, though the name says allergic, it's not an allergic response. So you don't have eosinophilia. Okay, so there is no eosinophilia. Eosinophilia is negative. Okay, this is the difference between ABPA and extrinsic allergic alveolitis. In extrinsic allergic alveolitis, there is lymphocytic infiltration of interstitium. Non-caseating granuloma can be there. And the radiological features in asthma, there is hyperinflation. And ABPA, there is migratory peripheral infiltrates, atelectasis, and there can be bronchiectasis. Late stages, there can be also fibrosis. In extrinsic allergic alveolitis, it is diffuse alveolar interstitial infiltrates. Late stage, it can happen and show reticulonodular interstitial opacities. Skin test to aspergillus antigens is positive in ABPA and extrinsic allergic alveolitis as well. But in asthma, immediate test can be positive. Okay. And eosinophilia is classical of allergic bronchopulmonary aspergillosis and not extrinsic allergic alveolitis. Though in the name there is allergic thing, it's not like a allergic response. IgG aspergillus precipitans is positive in ABPA as well as extrinsic allergic alveolitis. Serum IgE levels is again elevated in ABPA and normally in extrinsic allergic alveolitis. So IgG precipitants can be there, but IgE and eosinophils will not be there in extrinsic allergic alveolitis. There was a question which asked about extrinsic allergic alveolitis, that is why I have added this slide. Next question, a 25-year-old man presented with agitation and central chest pain. He had been taking cocaine earlier that day. On examination, had a pulse of 100 beats per minute and a BP of 170 over 110. What complication is most likely? So cocaine, which is like a CNS stimulant, and there is like a high metabolic state, so it can be associated with your hyperthermia. Okay, and they can also have cardiac side effects. So that is hyperthermia. Next question, a 51-year-old woman presented with a 6-month history of intermittent episodes of arthralgia, rash, and fevers. She complained of increasing fatigue, breathlessness, and swollen ankles over the previous 2 months. On examination, she had a purpuric rash on the lower extremities, the right-sided pleural effusion. Urine analysis showed blood 1+ and protein 3+. So we'll see what is she having. She's having arthralgia, rash, and fevers for the past 6 months. Okay. Now she is having increasing fatigue, breathlessness, swollen ankles. She has purpuric rash over lower extremities, right-sided pleural effusion, and blood 1+ and protein 3+ in urine analysis. ESR is high. Creatinine is also a little bit elevated. C4 complement is low. ANA is positive. Rheumatoid factor is also positive. So female, there is arthralgia, rash, fever, there is pleural effusion or serositis, okay, there is renal involvement, okay, and serum C4 is low. All suggest SLE. What is the most likely diagnosis? It is SLE. SLE is associated with low C4. This was another question. Which complement is deficient in SLE? That is C4. And they present with rash, photosensitive rash, malar rash. They can have arthralgia. They can have renal involvement, that is called lupus nephritis. Again, have 6 stages, stage 1 to 6. And they can have, they can have rheumatoid factor positivity. Can happen in both rheumatoid as well as SLE. And ANA is mostly positive. They also ask sometimes what is the most specific antibody for SLE? That is anti-dsDNA, double-stranded DNA, anti-dsDNA. Anti-Smith is also most likely positive in all cases. So it is most specific one is anti-dsDNA, but ANA is also positive. And complement deficiency associated with SLE is C4. Okay, microscopic polyangiitis is P and K positive. IgA vasculitis, not the cause here. Mixed cryoglobulinemia, no. Rheumatoid arthritis. So the clinical features of SLE, you can remember it like empty psoas brain, malar rash, discoid rash in chronic cutaneous lupus erythematosus, serositis like pleural effusion, oral ulcers, alopecia, and your rash is also photosensitive, okay? Synovitis in more than equal to 2 joints, brain manifestations, renal, that is lupus nephritis, which again has 6 stages, anemia, autoimmune hemolytic anemia, and immunological features, that is your antibodies. Next question, a 64-year-old man presented with increasing pain in his right elbow and tingling in medial aspect of his right hand. His job involved using a sledgehammer. Examination was normal. What is the most likely diagnosis? So we'll look at the distribution of pain and we'll try to correlate it with the nerve or dermatome. It is right elbow and medial aspect of right hand. Medial aspect of right hand, what is supplying? Ulnar nerve. And where is the pain? It is right elbow. Ulnar nerve is passing in that medial epicondyle behind that. and there can be nerve entrapment, especially his job involved using sledgehammer. So there can be a ulnar nerve entrapment or entrapment neuropathy. That is ulnar nerve entrapment. We look at the other option, C6 radiculopathy. C6 dermatome is also supplying the lateral aspect of forearm, okay, which is not happening here. Compartment syndrome, there is nothing suggesting compartment syndrome. Compartment syndrome will also affect other nerves. Lateral epicondylitis, no, uh, because he's having a tingling in the medial aspect. Median nerve entrapment, no. Median nerve entrapment happens in carpal tunnel syndrome, but the distribution is not like this. So this is ulnar nerve entrapment. We'll see the dermatomes of hand in the palmar surface. In the medial surface, it is medial side 1.5 fingers, it is ulnar nerve, and 3.5 fingers, it's median nerve. A little portion here, it's radial nerve, and here again in the thenar eminence, median nerve, hypothenar eminence, ulnar nerve. On the dorsal surface, 2.5 fingers, radial nerve on the radial side, and median nerve on the ulnar nerve on the medial side. And the tip of this fingers is supplied by median nerve. First web space is classically supplied by the radial nerve. Next question, a 75-year-old woman present with 6-month history of an ulcer over the right angle. She had a history of right deep venous thrombosis 5 years previously. On examination, she had a superficial sloughing ulcer 6 cm in diameter over the medial malleolus. What is the most appropriate investigation? So it is ulcer over the right ankle, and she had DVT also previously. So she had venous insufficiency previously. Now she is having superficial sloughing ulcer over the medial malleolus. Medial malleolus is classical of your venous ulcers. So she is having a venous ulcer. What is the most appropriate investigation? We look at the options: angle brachial pressure index, bacteriological swab of ulcer, bilateral lower limb arteriography, right leg venography, venous duplex ultrasound scan. See, we'll look at all options. Angle brachial pressure index, what is it indicating? When you do that investigation, you'll know if there is some arterial insufficiency. Why are you doing that in a venous ulcer? Because for venous ulcer, the treatment is compression bandaging. But once you're doing compression bandaging, if there is an arterial insufficiency, it will worsen the condition. So you have to rule out arterial insufficiency. That is why you do an ankle pressure index. Other things, bacteriological swab of ulcer. There is nothing suggesting any infection or sepsis, so that is not needed. Bilateral lower limb arteriography. Why both limb and why arteriography? Not needed. Right leg venography. We know there is some insufficiency in the venous system, and there is already a venous ulcer. That is not required. Venous duplex ultrasound scan not required. So the answer is angle brachial pressure index, and that is to rule out arterial insufficiency before compression bandaging. So that's all for today. We'll come with the rest of the question tomorrow. So follow for more updates and questions and other things regarding MRCP. All the best for your exam. So keep studying. Thank you.